And the first presenter is going to be Dr. Rothberg from Duke University. He's going to speak on the year in review for focal therapy. He will be addressing the most pivotal papers 2023-2024. Michael.
Okay. Good morning, and thank you for the opportunity to speak on this important topic. In reviewing the literature in our field that's been published from 2023 and 2024, one theme seems constant, that year to year, more and more evidence becomes available to sort of support practices in our field. And so there were a lot of really excellent publications that were available to choose from for this. And so my thinking was I wanted to focus on those papers that really sort of emphasized the potential and where our field may be going in the future. So the first paper I'd like to discuss, this is Prediction and Mapping of Intraprostatic Tumor Extent with Artificial Intelligence. This was the paper that was done from the UCLA and Stanford group. They developed and trained an AI model using tract biopsy data. They then developed an encapsulation confidence score using whole mount histopathology calibration as a data set. This AI model and ECS were then retrospectively evaluated using an independent whole mount histopathology test data set. So going into just a little bit of the details about how this was developed, the input data for the AI model consisted of T2-weighted MR images, along with prostate and region of interest segmentations. They also input the tract biopsy coordinates and then patient information such as serum PSA and also biopsy histopathology. This was then put into their model, and as you can see, there's both imaging inputs as well as biopsy and pathology inputs. For each T2-weighted MR image that was submitted per patient, they developed, there was an 8-layer 3D convolutional neural network that generated an image vector from this T2-weighted MR imaging. Additional features from PSA, spatial relationships between biopsy cores, the segmented region of interest, and relationships to the prostate capsule were also included in this. And then their AI model developed estimates of the likelihood and the probability of clinically significant prostate cancer. So there were several models. These then produced prediction probabilities between 0 and 1 of the likelihood of clinically significant prostate cancer being present in any one sample's location. This model was then subsequently used to predict clinically significant prostate cancer probability at all intraprostatic MRI voxels, and then this produced what they call a cancer estimation map, which is abbreviated as CEM. And so this was then used to develop this encapsulation confidence score, and this was based on a retrospective review of 50 whole mount radical prostatectomy specimens. The inclusion criteria for this were those that had single region of interest that were visible in MRI. They had to have intermediate risk disease, grade group 2 or 3, and this cancer had to be confined to a single hemisphere or in the anterior portions of the prostate. These whole mount tumors were then segmented in slides, were registered to preoperative MRI, and then the proportion of cases with negative margins determined at each CEM threshold. The ECS is shown here on the slide here. It's meant to serve as a novel metric to facilitate selection of focal therapy margins. The plot here provides a graphic representation to be able to assess treatment success probability based on ECS versus treatment burden, which can be shown on the margin volumes that are there. So the CEMs were generated and then thresholded to produce an AI model margins for each case. Default AI margins were compared to what they defined as 3 conventional margin variants. First would be, those were defined based on ROIs that were determined from PIRADS scores and what was visualized on multiparametric MRI. That alongside with biopsy confirmed clinically significant prostate cancer. Then the second variant was that ROI with a 10 millimeter margin. And third would be a hemigland margin that encapsulated all preoperatively evident clinically significant cancer, defined as either the left, the right, or the anterior prostate hemisphere. Negative margin rate was assessed as the proportion of margins that achieved either complete encapsulation of all clinically significant disease or complete encapsulation of the index lesion. And so the results that I'd like to highlight from this is a table that shows comparison of conventional margins with the AI default margins that's seen on the rightmost column of the table, along with the conventional margins that are identified as the original ROI from the MR visible lesion, then the 10 millimeter expansion, and then the hemigland margins that are shown. When we look at the top, the sensitivity values are reported when we compare the default AI margin of about 97% sensitivity. That is significantly improved compared to the original ROI, which is about 37% sensitivity. It's also significantly improved compared to the hemigland margin as well. We then look at the negative margin rate, comparing the default AI margin that's shown there with a rate of about 90%, and that is significantly improved over the original ROI, which had 0 out of 50 with respect to a negative margin rate. I think that speaks to what we as a field know about size estimation of tumors on multiparametric MRI and how they typically will underestimate what's truly there in terms of biologically. And so I think that this was a very interesting and very important paper, and it speaks, I think, to the potential of what the future of our field holds in terms of diagnostic capabilities and accuracies for clinically significant disease, as well as for treatment planning for focal therapy. The second paper that I'd like to talk about is the role of multiparametric MRI and MR-targeted biopsy in the diagnosis of radiorecurrent prostate cancer, and this is an analysis of the Forecast trial out of the UK. This is a prospective paired cohort diagnostic study in which, at the end of the day, 84 patients with biochemical recurrence after radiation therapy or brachytherapy with or without ADT underwent choline PET CT, bone scan, and multiparametric MRI for staging at the time of biochemical recurrence. MR visible lesions were scored on a Likert scale with respect either to PIRAD score or the novel Radiorecurrent scoring system that was coined by the group over in the UK as well. They then performed cognitive MR-targeted biopsy, whereby they took 4 to 6 cores per lesion, and then all patients who were eligible then underwent transperineal template prostate mapping biopsy at 5 millimeter intervals based on a brachytherapy grid. So to understand exactly what it was that was done and sort of the rationale for what they did, certainly, as we all know, tumors can be defined as either MR detectable or MR undetectable. And for those that are visible on MRI, there are MR targeted lesion sampling. Those are the orange cores that are shown on the top on the biopsy schema. And then all patients underwent transperineal template prostate mapping biopsy in order to determine whether there were MR invisible lesions present within the prostate. They then did a comparison between MR targeted biopsy to 3 additional biopsy strategies in order to determine the added diagnostic value of sampling other quadrants within the prostate in terms of detecting any cancer or clinically significant prostate cancer. And the different strategies are shown here. So strategy 1 would just be a MR targeted lesion sampling. Strategy 2 would be a targeted sampling plus a biopsy of another ipsilateral quadrant. 3 would be targeted plus a contralateral posterior quadrant sampling. And then strategy 4, which would be the most amount of biopsies done, is targeted plus systematic biopsies of an ipsilateral quadrant and a contralateral posterior quadrant. And because there is no sort of standardized way for our pathology colleagues to make a diagnosis and assign a Gleason grading score for patients who have undergone radiation therapy or ADT, this analysis was done based on detection of cancer of any grade or any length. So the first table to present based on these results, this shows a number of patients in quadrants who had cancer detected on transperineal template prostate mapping biopsy with or without targeted biopsy of MR lesions. And the thing to sort of understand is on the top part of this slide, they give results based on whole gland analysis, and in the bottom part of the slide, it's based on a quadrant analysis. And then as we move over from left to right, it's any cancer that's detected, and then they sort of stratify it even further in terms of promise definition 1 cancer with grade group 3 or higher, and then promise definition 2 cancer with grade group 2 or higher. Based on this result, there's a diagnostic accuracy analysis for whole gland, Likert greater than 3 or greater. Sensitivity was about 95 to 98. Specificity was quite poor for this, 0.19 to 0.21. As you move up with Likert 4, the sensitivities remain similar, although they decrease a little bit, but the specificities improve up to 0.63 to 0.82. On the quadrant-based analysis, sensitivity for Likert 3 or higher was 0.66 to 0.69. Specificity was about 0.5, and Likert 4 or greater, the sensitivity dropped somewhat. Specificity, however, improved 0.89 to 0.94. This is a comparison of pathologic characteristics between prostate quadrants on MR undetected versus detected cancer, according to lesions that were characterized as Likert 3 or greater on multiparametric MRI. The take-home message from this is that MR-detected tumors had significantly longer maximum cancer core lengths. Intuitively, this makes sense. With a higher grade group, there was a significantly higher proportion of tumors that were detected by multiparametric MRI. This also intuitively makes sense as well. The last slide to report from this is an analysis of the different biopsy strategies that were done. Looking at the slide itself, they break it down by any cancer on top, promise definition 1 in the middle, and promise definition 2 on the bottom. And then as we look at the different columns moving over, strategy 1, that's the MR visible targeted biopsy only. Strategy 2 and 3 were a single additional quadrant that was template sampled, and then strategy 4 were 2 quadrants that were sampled. Take-home message from this is that when a comparison is done between strategy 1, which was the least amount of biopsy that's done, and strategy 4, which is the most, there were significant differences in number of patients with cancer that were harboring additional tumors in unsampled quadrants. And so that was statistically significant for patients with any cancer, patients with promise 1 and promise 2 definitions for cancer. And so based on this, they determined that about 60% of patients were eligible for a salvage focal ablation, and they break down what their recommended treatment strategy would be for these patients who they deemed eligible. The take-home message from this is that MR-targeted biopsy will diagnose the majority of cancers present in the radiorecurrent setting. However, if planning for salvage focal therapy, targeted biopsy alone is insufficient due to rates of additional tumors identified in unsampled quadrants and the potential for undertreatment if you were planning a focal therapy based on only MR-targeted sampling. The last paper I'd like to present is from Dr. Stricker's group. This is irreversible electroporation of localized prostate cancer, downregulates immune suppression and induces a systemic anti-tumor T-cell activation. These are the results of the IRE immuno study. This was open to patients with intermediate risk disease, either grade group 2 or grade group 3 with a PSA less than 20. In total, there were 20 patients who met this criteria and underwent IRE. 10 patients as control underwent radical prostatectomy. They collected blood samples from patients at baseline prior to treatment and at 5, 14, and 30 days post-treatment. And then they performed transperitoneal template mapping biopsies at 12 months for those who underwent IRE. Based on results of flow cytometry, where they looked for frequencies of certain effector T-cell populations within systemic blood samples, patients with IRE showed significant upregulation of CTLA-4 on both CD4 and CD8 T-cells. This was immediately after treatment, but most pronounced at 14 days after treatment. So if we look at the frequency plots here, we have CTLA-4, CD4 cells and CD8 cells for IRE, which are shown on the left side, and then similarly for patients who underwent radical prostatectomy on the right side. CTLA-4 expression on these CD4 cells were significantly higher after IRE compared to observed levels in patients who are treated with radical prostatectomy. And this is an interesting finding, certainly. They then did a linear regression analysis and determined that IRE-induced CTLA-4 upregulation of both of these effector T-cell populations is positively correlated to tumor volume. So with larger tumors and larger ablation areas, there is a relationship in terms of systemic immune response. This is an analysis of immunosuppressive regulatory T cells that were in circulation following both IRE and radical prostatectomy. And the importance here is that they actually split between those that are active and resting in total. So it's one thing for these cells to be present, but it's another thing for them to actually be active and performing an immunosuppressive function. They report significant decreases in regulatory T cell frequency shortly after IRE, peaking at 14 days, which was similar to the effector T cell response. This response here lasted up to 30 days after treatment. Both activated and resting regulatory T cell subsets were independently downregulated in the IRE population. Importantly, they did not see these changes in immunosuppressive T cell frequencies in patients who underwent radical prostatectomy.
We're just going to hug him.
They then identified 10 patients from the IRE group who had really exceptional effector T cell activation responses. They underwent in vitro T cell stimulation, interferon gamma ELISpot assay to determine the presence of tumor antigen-specific T cell responses. So similar to understanding whether or not immunosuppressive regulatory T cells are present or active and actually performing an immunosuppressive function. The importance here is if there are if there are effector T cells that are producing a response, are they actually specific to prostate cancer associated tumor antigens? Of the 10 patients who they identified, 8 were immune competent, 6 demonstrated a specific response to antigens specific to prostate cancer. Some of these patients had this kind of a peripheral response present prior to treatment, and their responses in the presence of these effector T cells were maintained or boosted after IRE treatment. One patient had a de novo presence of these cells that were specific to tumor-associated antigens. So I think that the take-home from this is that this is an early study showing some of the important systemic immune responses to focal therapy, specifically IRE, and a lot of potential in the future to use this kind of technology and understand the immune response to these kinds of treatments to improve our outcomes. So thank you.